very similar backgrounds, but different levels of expertise as well. Just before we start, I'd like to acknowledge the traditional owners of the lands on which we all are meeting today, depending on where you are, as the Wiradjuri people of the Kulin Nation here in Melbourne. Pay respects to their elders, past, present, and emerging, past, present, and emerging, and extend my regards to Aboriginal and Torres Strait Islander people who are joining us today. So today's session will be recorded and be available on the NCAS website after the session. If you've got any questions, we've just spoken to our two speakers, and they'll do the Q&A at the end of both of the talks. So save your questions up, and we can have a bit of a combined chat at the end. If you've got any questions, pop them in the Q&A at the bottom of the screen. If you want to ask a question live, let us know, and we can try and make sure that we can. I can try and work the technology, or hopefully Caroline's much more adept than I am. I think we'll get going. The first speaker today is Professor Denis Verwilghen from the Goulburn Valley Equine Hospital at Gilkerson in Victoria. He works at the University of Melbourne as well. Denis is a European board certified surgeon, an academic. He has a strong focus on clinical governance, antimicrobial stewardship, and infection prevention in equine and veterinary medicine. He leads quality improvement initiatives aimed at reducing inappropriate antimicrobial use through targeted education, structured protocols, and evidence-based decision-making. Denis is actively involved in national and international efforts to improve antimicrobial prescribing practices in equine practice, advocating for a culture shift towards responsible, outcome-driven care. His work combines hands-on clinical leadership with academic insight, striving to align daily practice with broader One Health goals in combating antimicrobial resistance. Denis, I will turn this over to you.
Thank you, James, for that introduction, which is far too much credit, I would say. I probably wrote that myself and submitted it for you to be read through. But anyway, I would say that indeed, particularly last year, there was a great effort in antimicrobial stewardship in equine that came out with the national AVA-driven antimicrobial guidelines for horses. So whoever is on here and hasn't seen that yet must really look that up. It is an open access publication and really, really valuable as a guideline. So thank you, AVA, for that initiative and all the authors that have participated there, particularly Laura Hardefeld, that is a driving force in that. I will try and make the magic of online webinars work and share my presentation for the day. If I can just confirm that people can see my slides. Yes. Okay. So my talk for today is about the effective implementation of an antimicrobial stewardship program at an equine hospital. So who do I represent here? I represent a team of people that you can see on this slide, which is Gabby Van Galen, Kirsten Bailey, Chelsea Burden, Max Hannon, Stacey Sullivan, Josh Slater, and Laura Hardefeld that were part of this initiative at Goulburn Valley Equine Hospital. Goulburn Valley Equine Hospital is a wholly owned subsidiary of the University of Melbourne and functions as a teaching hospital. Like, we're a private practice, so we're really a private entity, and we function like an equine hospital. So we are very representative of the actual field of equine hospitals here in Australia. So hence making this initiative a good example of what can be done within a private equine hospital if the will is there. So I have no conflicts of interest to declare here. We did have no funding whatsoever to do this, and everybody was involved in this out of their free will. Antimicrobial resistance does hit us in the veterinary world just as it does hit the human aspects. We see it very rapidly emerging as a threat to the care of our equine patients, with resistant isolates from the general equine population being reported. On top of resistant isolate from hospital-acquired infections. And we see a lot of treatment failures, increased cost of therapy, pan-drug-resistant organism reported by equine veterinarians over Australia, that we see becoming more and more frequent. And I think, like all the people that are on this webinar are not surprised about that, or they are very well aware of these issues. I must say, with having a European background and having practiced for the biggest part of my life on the European continent, including in the Scandinavian countries, for about 10 years, I can see a huge difference between what we have seen there and what we see here. And Australia is hit by this problem much more than I have been used to, unfortunately. Based on that, on that knowledge, there has been a driving force globally within the equine community to effectively reduce antimicrobial use within equine practice. And these things have been supported by a whole series of evidence-based clinical case reviews, where you effectively see that the summary of antimicrobial use in equine practice is less is more. And that based on the fact that elective arthroscopy, if you take several examples of procedures that we do, in elective arthroscopies, there doesn't seem to be any more infection or higher infection rates in cohorts of patients where there was antimicrobial prophylaxis versus none. So the incidence of surgical site infection in arthroscopy in horses with or without antimicrobial prophylaxis is about 0.5. So it doesn't seem to be protective. We see that for colic surgeries, and in my career, over nearly 25 years, I have seen colic horses receiving antimicrobials for about 10, 15 days in hospital and then sent home with 2 or 3 weeks oral antibiotics after that, to having horses just receiving 24, 48 or 72-hour protocols, depending on the effective intervention that they get. And when we talk colic surgery, we're talking laparotomies, celiotomies, like open abdomens. And we don't necessarily see a difference in these outcomes when we look at whether or not these horses receive extended or not. And what I'm saying is not totally true. We do see a difference in outcomes, and that is related, that it becomes more and more clear. We see difference in outcomes not on the measures that we used to look at, like surgical site infections or also these abdominal infections and so forth, but we recognize more and more complications, particularly gastrointestinal complications, linked to antimicrobial use in horses as well. And we start to realize that horses may have 0.5% chance of getting a surgical site infection when they have an arthroscopy, but a 6% chance of getting an antimicrobial induced diarrhea and potentially die from that. So that recognition is developing. Despite that, there's still a big fear within our industry, a fear for change, like we always have. Fear for health, fear for outcomes, fear for reputation. The reputational fear is one that is also driven by a veterinary boards and law cases and things like that, where veterinarians still fear that if they haven't provided the animal with antimicrobials for a surgical intervention, that they and the animal develops an infection, they will be held liable for the fact of not giving that, right? And in a survey we did a while ago, that was clearly represented, where when we asked, are you in fear for reputational and legal outcomes if you don't give the animal antibiotics and it develops an infection, most of the respondents said yes. But when we asked them the same question in relation to the fact the horse may develop side effects to the drug, most notably diarrhea or antimicrobial induced diarrhea, they would just classify that as a inherent risk of using that drug. So there is a bit of a disconnect there, but there's a lot of fear of practitioners from many levels to change those habits. However, there is this call for antimicrobial stewardship in veterinary practices, where this One Health Master Action Plan for the Australian National Antimicrobial Resistance Strategy that everybody here is well aware of. And that does not only include equine, that's also human and small animal hospitals. And very few, unfortunately, equine hospitals relate to that or abide by this. Anyhow, with all that background information, the idea within our hospital, which is meant to be a hospital that leads by example, as we are an educational institution, or our reason of existence is to educate students. The idea was that we needed to take the forefront in this and to start and develop and implement a antimicrobial stewardship program within this hospital. And the objective of my presentation today is to describe what we have done, describe the process, and describe the current outcomes that we have been able to achieve since. So we had several phases in this. Gary van Galen, which is a European boarded specialist in internal medicine and emergency and critical care for horses, and myself as a boarded surgeon and dentist, started at Goulburn Valley in January 22. And we started then a stewardship champion program. We effectively set up the idea, tried to change the philosophy around use of antibiotics within the practice, effectively warming the clinical the clinical staff or the entire hospital staff about the idea. In August 2022, we had our first workshop with all the staff, not only veterinary staff, but also administrative and technical staff. In March 23, we had our second workshop. And in this initiative, we were aided particularly by Laura Hardefeld and Kirstin Bailey and Josh Slater from the university mother house to help us do that, which I think is an important aspect in these implementations, is to have help of external key holders, and that it is not just a message that comes from inside. The inside is important, but there needs to be some kind of outside support. So from the perspective of this little study, we looked at antimicrobial use in terms of antimicrobial sales that we had, and case numbers in the hospital through our practice management software, and calculated dosage used per 100 cases, right? And standard using standard dosages out there. And we have actually 4 periods, not 3 periods like it says there. We have the prior to the stewardship initiative, which is the period 2017-2022, the January 22 to August 22, which is the stewardship champions have arrived. Then the August 22 to March, which is the period where we have had the educational components, the workshop, the design, the co-design with the group of the in-house antimicrobial stewardship protocols. And then we have the March 23 onwards, where we have the protocols implemented. So in our first workshop with all the staff, we had Laura presenting the rationale behind the implementation of antimicrobial stewardship in equine practices and farms. We had and we assigned different clinicians with protocols to co-design, like everybody was given an area to create our own in-house antimicrobial stewardship protocols for surgery, for reproduction, for dentistry, and so forth. Created our own little work groups, which again is quite important. So you get internal stakeholder engagement. We haven't just thrown a pre-designed protocol at everyone, despite the fact that, we had them available. Both Gabby and I and Laura and everybody involved could have just given something to everyone. We really made sure that it came from the internal stakeholders' own initiative. We use the antibiotic use in horses framework from that is available here in Australia, with the variation in colors of classification of low importance, medium importance, high importance, and highly important to avoid green, yellow, red, and black system. This also included in the first workshop the reorganization of our pharmacy using the same color coding and implementation, where, as you can see on this image, the effective antibiotics are set on the shelf with their respective color, so that when people pick up things, there is a visual reminder of what they are taking and how things are happening. In our second workshop in March 23, we also then discussed the antimicrobial use for non-antimicrobial purposes, like the use of certain antibiotics post-colic, for instance, as gastric, or not gastric, like intestinal motility, or sorry, I'm losing my words there. But anyway, for users that are not effectively anti-infectious, we rediscussed protocols for fever use in the field, diarrhea, endometritis, and set protocols for our next workshop in May 23, where the protocols established were discussed, and the fourth workshop went for postpartum mastitis and perioperative. So every time we had the little work groups presenting the outcome, and we came to a consensus amongst the internal stakeholders about how we were going to proceed and what the protocols were, which is again important, so that during clinical work at rounds in the morning, when we do cases, we had a fallback to everybody to say, well, listen, this is what we agreed together, how we were going to proceed. So why are we doing it differently in this particular case? There was a very good engagement out of that those workshops. It also highlighted the staff that yes, we are going to reduce the antimicrobial use. That's the idea, but that means that we will have to focus maybe on other aspects. And this is a global package. This is also improving hand hygiene, improving hygiene measures overall in the practice when it is sterilization, equipment, surgical theater, instruments, workflow, etc., etc., etc. So there was a big push for implementation and development of the 5 moments of hand hygiene in veterinary medicine. For anyone interested in that initiative, I can put all these posters available to you. Just pop me an email. I have them for all species, not only horses, but also small animals and exotics and ruminants to set up in veterinary practices. The results of our little study or our little initiative showed that we had this period before the stewardship champions' arrival. We were using between 2017 and 2022 in our hospital 209 dosages of antimicrobials per 100 cases, of which 55 dosages per 100 cases were high importance antibiotics. With the arrival of the 2 stewards in that period, January 22 to August 22, or the so-called SC period, that dropped to 135 dosages. Still not doing that well then on the high importance, with only 51 doses, or still 51 dosages. And then you see a progressive decline in the August 22 to March 23, or the more educational antimicrobial stewardship protocol implementation period, with a drop in dosages there to 41 high importance and 133 dosages. And then is the March 23 onwards situation, and I have the values here first up till April 23, where you start seeing a progressive decline on this graph of the antimicrobial usage. You see most particularly the status in April 23, where the usage of amikacin has significantly dropped, which was quite high in 21, and dropped significantly to 1 in 100 cases there. But more importantly is then to look at our longer term status, or the status in October 25, where when we look at the low, medium to high use antimicrobials, we see that we have dropped to a near to zero value of high importance antibiotics in the 24-25 period, and the overall usage of low importance antimicrobials has dropped to about 50 dosages per 100 cases. And remember, we're coming from over 200 in the period prior to 2022. There is a small peak there that you can see in 24, which is interesting, from the medium use of a medium category, and that is due to a Clostridium diarrhea outbreak that we have had in the hospital. Well, the outbreak didn't happen in the hospital, but we were presented with several foals at the same time that had Clostridial diarrhea in surrounding farms, which led to an increased use of metronidazole in that period, right? We also see that this use of higher category importance antimicrobials has dramatically been reduced in the period since 2022. We see no use of rifampin, no use of amikacin, and no use of polymyxin B. Polymyxin B is what I was after a minute ago, which is very regularly used in equine practice with the belief that it is used for reducing endotoxemia in cases post-colic. So it's not used for the antibiotic effect, but for others. And these three drugs haven't been used in the practice in that time frame. So there is a critical reduction in the antimicrobial use there. In our discussion here is drastic. We see this drastic decrease in use in certain conditions, particularly post-operative colic, diarrhea cases, despite the fact that we have no active surveillance programs in veterinary medicine nor in our clinic. Our clinical impression is not that we have increased our number of surgical site infections or issues within the hospital. If at all, we have the idea that we have less antimicrobial induced diarrheas or complications from that perspective in the population that we treat. This is from a first review, and hopefully, the time will show that we can maintain this further in the next year. At present, we see that this trend has continued within our hospital. The idea, which was quite stressed to our staff at the time, was that we were not aiming at eliminating the use of antibiotics within our practice. We were aiming at reducing the use. We were aiming at de-escalating, at providing reasonable and evidence-based protocols, not just, the in-case scenario, or I want to protect myself. And we want to have discussions. And I think a very important aspect that I see that has changed within the discussions we have in the hospital and the way we approach antimicrobial use is that before, and I see that not only here, but I see that, in several places that I have worked in Europe, we used to have, as clinicians, amongst each other, defend why we provided or why we didn't provide the animal with antibiotics. Like the provision of antibiotics for a condition or an intervention was the standard. Here in the hospital at present, we have shifted the narrative. We're in a situation where every morning at rounds, when we discuss the patients, we have to justify why the animal is still on antibiotics, right? Not why it doesn't have any. So I think that's a very important cultural shift that has been achieved within the environment. And there is no aggressivity, there is no bad feelings about being questioned, which used not to be the case, right? Everybody was always very tense and very annoyed in having the discussion about it, and that's not the case. There are obviously some limitations to this study where We've used assumed dosages calculated. We might have seasonal changes and case variability, like we were shown with some peak in diuretic falls, but we can generally explain what happened in those. We also use this as a large leverage for improvement in standard of care, and that's very important when we do that, to also engage the leadership and management in those discussions, so they understand what we are about. They also understand why we are asking for investment in better hygiene and so forth. So this led us to buy a washer disinfector, which is quite unique in veterinary settings, to improve the disinfection and care of our equipment, better, cleaner surgery. So this shows a successful implementation of a stewardship program in an equine hospital with substantial impact of less antimicrobial use, no adverse clinical outcomes. There's also a large educational benefit to this, as we are a educational entity. As primary reason, our students are also exposed to this rationale, and I hope that that will translate in changes within effective clinical practice in the future. So I'd like to thank most particularly Emma Clue and Beth Denio, were driving this from an administrative and technical point of view, and then Gabby Van Galen, who is really a driving force behind that. And that's from Goulburn Valley Equine Hospital, which unfortunately is likely not to be able to continue these initiatives, as our stakeholder or ownership, the University of Melbourne, has decided to stop their stake in our hospital. So we will have no more students, no more opportunity to spread the antimicrobial stewardship message in the future, as it will be the end of our operation very soon. Thank you for your attention, and I hope that has inspired people to say that it is possible, it can be done. Thank you for your attention, and happy to take up any questions.
Thank you, Denis. Yes, sad news about the university's decisions. Anyway, what we thought we might do is hold the questions until the end. So I'll hand over to Maurizio Coppo for his talk, and then we can run the questions together. So Mauricio Coppo is a veterinarian with an interest in infectious diseases, One Health implementation, and international cooperation. Mauricio graduated from the Universidad de Chile. He worked in Chile, then subsequently in the poultry industry for several years before embarking on postgraduate studies at the University of Melbourne. Since completing his PhD, Dr. Coppo has had multiple research appointments at the Asia Pacific Centre for Animal Health, including in veterinary virology, avian immunology, veterinary microbiology, and international veterinary antimicrobial stewardship. Maurizio's professional experience, combined with his extensive research experience in veterinary microbiology, underpin his current work, which is focused on strengthening animal health and One Health systems in developing countries. He's worked with governments in more than 10 countries in South America, Southeastern and South Asia, and the Pacific region, providing technical support on managing antimicrobial resistance, facilitating cross-sectoral engagement, and advancing and advocating for a One Health approach to data interpretation and use and the formulation of science-driven policy. So Maurizio, I'll hand over to you.
Thank you very much, James, and thank you very much for the invitation. Good morning to all. I'll start sharing my screen. There, yes. I need to get rid of the flowing meeting controls. There.
No, that's good.
Right. Thank you very much. So today we're going to be talking about the different programs that we've been working on over the last, I want to say, 6 or 7 years now in different areas of the Asia Pacific. I when I was preparing the presentations during the week, Microsoft offered to create a image for my initial slide, and I said, yeah, go ahead. And that's what it came up with in Copilot. So I've added it. just for just because it's there. Why not? So I represent a large team of people. So this is the team that has been in charge of the delivery of one of our projects. It's called the AMR and One Health project for the Southeast Asia, funded by the Fleming Fund, the UK government, and we're going to talk more in detail about it later. But we have a very strong team at the Asia Pacific Center for Animal Health with capacity and with expertise in a number of different things: veterinary microbiology, bacteriology, virology, epidemiology, immunology, cattle, pig, and poultry medicine, bioinformatics, policy and implementation science, and more importantly for this talk, veterinary antimicrobial stewardship. The only person in the photo there that's not actually part of APCA is Angeline down here next to me. But she was an important part of our team for the delivery of AMRO, of the AMROSI, of the AMR and One Health project in Southeast Asia, doing the monitoring and evaluation. All right. So since 2019, we started delivering this program called the Fleming Fund Professional and Policy Fellowships. We started in phase 1 with 4 countries, which during phase 2 and this or a second group, and this is probably around 2023, we added an additional country, which was Pakistan. But over the last 6 or 7 years, we've had over 100 fellows. This is a project that's been in collaboration with our colleagues at the Doherty Institute. So over 100 fellows, of which more than half have been in animal health, or what our medical colleagues call the One Health areas. So that could be food microbiology, environment, water, and other things that are not medical or they're not human health. So we provided a very strong program on very different topics because we've had 50 fellows. We have essentially what we do is we develop an individual work plan for each of our fellows. And depending on their area, so they could be a laboratory person or they could be coming from a more of an epidemiological background. So depending on what they do, we will develop a specific training and mentoring work plan for them with some specific objectives. And then by the end of the period, which is normally, well, during the pandemic, it got extended because we couldn't travel. But in general, these fellowships have been between normally 1 and 2 years, except during the pandemic. And because we had such a strong performance during that program, that we were then invited by Fleming Fund to submit a proposal for this regional grant for Southeast Asia, and that would include Timor-Leste, Indonesia, Laos, Papua New Guinea, and Vietnam. And through this project, and this started in 2025, last year, or maybe late 2024. Yeah. So we've developed a number of in-country workshops, more than 15 possibly, and 2 regional workshops, which I'm going to talk about later, on different topics, but more importantly, in advancing a One Health approach to the containment of antimicrobial resistance in all these countries, and the use of data for stewardship and for policy. The other project that we've been involved in is Combat AMR, also in collaboration with a number of human health organizations, including the Doherty Institute. During phase 1, we worked in Fiji, Samoa, and the Solomons. Papua New Guinea had a minor role in that project from an animal health perspective. And during phase 2, which is ongoing, we are working with Fiji and Samoa, continuing some of the work, building on the work that was done during phase 1. One of the objectives of all of these projects and all of these programs has been to gather and start collecting data so that we can use that data for stewardship or for policy making. But as you can see, and this is a map of all the countries where the Fleming Fund was operating. Of course, we were not we didn't have any involvement in Africa, but we did have involvement with all the countries in South and Southeast Asia except for India, Bangladesh, and Sri Lanka, essentially. So we were in every country. But as you can see, there's significant differences between the different countries. So the availability of data and the circumstances of each country were very, very different. So it's hard to compare the situation or work together in a situation where you have Pakistan with 200 million people compared to Timor-Leste or Bhutan. Bhutan has 500,000 people or thereabouts, less than 1 million. So the situations vary largely, and there's also variations there in the development of the livestock and poultry and aquaculture industries and systems, the availability and composition of the animal workforce. So Pakistan will have thousands of veterinarians compared to Papua New Guinea, where there's maybe 2 or 3. Same with the availability and regulation around antimicrobials. Bhutan, for instance, has very high regulation in the use and the prescription of antimicrobials because all of the antimicrobials are provided, purchased, prescribed, and provided by the government. Different to Nepal, where you can just go and buy them over the counter, possibly in the majority of agri-vet shops. And then this is thinking from an animal health perspective. And there's also variations in the professional public awareness, also varying depending on the size of the country and other circumstances. So I'm just going to give you a couple of examples of how this varies between countries. So one of the focus or the foci, let's say, or the focus of this project has been to perform surveillance of healthy poultry in all the different countries, just to have a baseline data. And because these are projects that are called One Health, but the main focus is human health. So we're not really looking at pathogens that cause disease in animals. We're looking at pathogens that may be zoonotic or that could go into the food chain and have an impact on human health. So this is example country 1. I'm not going to say which country, but it's a very small country, very little animal production, very few poultry production systems. This we're talking about 71 samples tested over a period of maybe 2 years. And the resistance that was observed in those, and this is E. coli isolates, as you see, there's some resistance, 39 or 40% to ampicillin, some resistance around 13% to trimethoprim sulfa, and around 11% to ciprofloxacin, and then no resistance to other antimicrobials, or very little. So this is example country 1, compared to example country 2. And this is a very different situation. This is 200 isolates from one of the countries that we've been working with high levels of, let's say, industrialization in their production. This is, again, healthy poultry. But as you see, the prevalence or the proportions of resistance that you can see against the different antimicrobials is quite high. So anywhere between, well, there's a few that are low, like this one here. So this would be fluorphenicol, which is a very commonly used antimicrobial for the production in animal health, in animal production systems, mainly pigs, but also in poultry and in aquaculture. So there's lower levels again in resistance to that antimicrobial, but as you see, the majority of them are above 90 or 85%. And so this is again a different situation, different country, different number of samples, but it's essentially to illustrate how much variation there is between the countries, and therefore the decisions that need to make and the programs that you need to implement to address this issue are very, very different for each of the countries. Yeah. One of the main things that we've observed in different countries, and this on the right is a photo of one of our Fleming Fellows from Nepal collecting samples from cattle, but has been the enormous gap that exists between human health and other sectors. So hospitals are data-making machines. We don't have that level of data from an animal health perspective, and definitely not from food or the environment. And this has to do with a number of different things or reasons, but mainly it's capacity in the laboratories. A lot of the countries that we were working on did not have any bacteriology capacity in their animal health laboratories. And so this funding and these projects that were implemented were the first time that they were exposed to start doing bacteriology on samples from animals, even if it was healthy animals. And that brought a number of issues that I'm going to talk about later. But it's essentially very, very big gaps in infrastructure and equipment, in resources, and for instance, access to whole genome sequencing. And what we found is that there's very limited understanding across sectors of these differences. So when we go to these meetings with our human health colleagues, they say, "Oh, but we need to do some, data sharing." It's like we don't have any data from animal health or from the environment or from food about AMR because it's not a priority at the moment. So it's an important problem, and people in these countries recognize it, that it's an important problem. But there's other competing priorities like outbreaks of disease, normally viral diseases that are killing their animals and that have impact in access to international trade, like African swine fever, which has been a disaster of a pandemic in the animal health world, avian influenza, and others. So essentially, this enormous gap that exists implies a significant problem for implementation of One Health projects in equal terms or in equitable terms. And so substantial investments are required. The other thing, so from all, like thinking about all the different countries that we've been, as I already showed, there's different prevalence or proportions of antimicrobial resistance depending on the countries. But because it's been done in healthy poultry around many countries, you can have an idea of what's going on around. Because not all the countries have published their results, and this is something that we'll need to focus in the next few years, I suppose, is doing a meta-analysis of the data that's been collected over the last 6 or 7 years, over the last decade, to figure out what is the situation generically for South and Southeast Asia, and then come up with some regional approaches to antimicrobial stewardship or decisions that need to be made from a regulatory perspective. But essentially, there's significant and widespread resistance to commonly used antimicrobials such as amoxicillin, tetracyclines, trimethoprim sulfa, and phenycols. Depending on the country, there's also some significant resistance to fluoroquinolones, as you saw, and sometimes also colistin, depending on whether it's been banned in that country. Again, regulation. Some countries have banned the use of colistin, others have not. Some countries are moving towards banning fluoroquinolones in animal production systems like Indonesia, but other countries are still thinking about it or moving towards, or waiting to have the data to be able to enforce that. We have some ESBLs, and these are extended spectrum beta lactamase E. coli. There has been implementation of tricycle projects, which are WHO, so human focus, but looking at ESBL producing E. coli in people, in the environment, and in animals, which I'm going to talk about later. Good thing is there is no resistance in general to other high priority, critically important antimicrobials, like, for instance, carbapenems, at least not in animals. Things to continue working on is analysis and integration of available data, representativeness of the data, and that will allow us to understand trends over time. The problem of this is, to be able to understand trends of time, we need to have sustainable surveillance programs, which without funding won't be possible. And so now, with the end of Fleming Fund, now in the next couple of weeks, the Fleming Fund finishes. So that means a lot of the countries will not be able to continue their surveillance, and therefore data collection, analysis, and use of that data will be paused, at least for who knows how long, unless they have budgetary options to be able to do that, which is not normally the case. So thinking about the tricycle or what is it program that WHO has developed, This has been published. This is the situation in Nepal. We've been able to see similar results from other countries like Vietnam. And this is just a dendrogram showing the phylogenetic relationships between isolates coming from animals, humans, and these could be sick or healthy humans, and from the environment. And in general, what we see is we have the pink color here is animals, and blue, light or dark blue is people. And as you see, the dark blue and the light blue are often together. I'm not sure. Let me see if I can show you my laser. Laser pointer there. All right, so these guys here, these blue ones, are together. So this is sick and healthy people. Their relationship is they're closely related to each other and with some isolates in the environment. And same here with animals, right? So we have isolates from animals that are also found in the environment. And this situation is similar across. Yeah, so we have animals here and some in the environment, and animals and some in the environment. But then some of the isolates in humans are also closely related, but there's very few. It's a sporadic situation, right? So in general, we have isolates from humans clustering together and away from the isolates from animals, which are clustered together as well, except in sporadic situation where you have some human isolates that are similar to those in poultry, but it's very sporadic. So this indicates, and this is a situation in Nepal, it's been published, a similar situation we're seeing in Vietnam, and we're waiting for the results to come from Bhutan. But essentially, it's a similar situation. So we have ESBLs in the environment that are coming from people. We have ESBLs in the environment that are coming from poultry, but in general, they're not the same. They're not closely related. What they do have is similar genes. So similar genes explain the ESBL phenotypes. So that means that maybe, and this is what I've written here, maybe there is some horizontal transfer in the environment of these genes between isolates from isolates in humans and or animals, because we don't know how these move. Right, so this is interesting. Yeah, so essentially, in general, the ESBLs in people do not come from animals, which is a really interesting finding. Because these countries, the majority of these countries didn't have laboratory capacity before for bacteriology and for detection of antimicrobial resistance, then that means that when they got data from healthy animals, they said, well, what can we do with this data? How can we use these data? And they started to use it for informing treatment of sick animals. And so when we saw this, we realized that of course that was wrong, because these are sick animals. These are E. coli, for instance, coming from the gut. So these are just indicated organisms. So that data, those data should not be used to inform treatments. But what we've seen is that in some cases, these data were used to inform treatments, and that would drive the use of more important antimicrobials in sick animals. So one of our key messages over the last few years has been healthy and disease AMR data is not the same. Active surveillance is for public health in the food chain. Passive surveillance or clinical microbiological results are for animal health and for treatment, and they should not be confused. So this has been a very, very strong part of our project over the last couple of years in Southeast Asia and with our fellows in South Asia and other countries. Other thing that we've learned is some data is better than no data when we're thinking about antimicrobial use and consumption data. A lot of the information that countries are using to generate their reports for international purposes, like reporting to the World Organization of Animal Health, is from import data or registration data. But in a lot of the situations, a One Health cooperation is essential, because sometimes registrations or these data are held in the ministries of health, not in the Ministry of Agriculture or the equivalent that's in charge of animals. So that means that One Health collaboration is essential to come up with some data that will be useful for reporting and for decision making as well. But we've also found that there's limited technical capacity for first gathering the data, analyzing the data, interpreting these data, and then generating reports that will be useful. So what we've been proposing is to use point prevalence studies, opportunistic data collection. Our experience in Australia from multiple years of research over the last, I don't know, decade or a little bit more is that different analysis of different sources of data, and this could be clinical records, big data from online databases, or from pet insurance data, or from point prevalence studies, all come up with similar results. So as long as they're representative in these countries, these studies could also be useful for that. What we found as well is what I've got in red there is combination antimicrobial products. And this was possible in Pakistan because we had a strong collaboration between our human health and our animal health fellows. And this is just a snapshot of treatment record data in poultry. And as you see, and these are layers or broilers at different ages. And as you see, there's this tendency to use combination products. So there's in the Drug Regulatory Authority of Pakistan registry, there's more than 2,000 commercial combination products that you can buy that are registered, not necessarily available, but at least registered. And of those, more than 50% contain colistin and or fluoroquinolones. And so some of them, like this one here, for instance, got penicillin, streptomycin, colistin, zinc, bacitracin, and doxycycline in the same product. Or what we've also seen is that maybe penicillin and streptomycin are in one product, and colistin and bacitracin and doxycycline in a different product. But people in the field are combining two different combination products to get not 2 or 3 antimicrobials, but 5 or 6. And so this is a big problem. Very, very big problem. And we suspect that it's not just a problem in Pakistan, but also in other countries as well. So that brings us to drug availability and regulation of access. These are photos that I took in Nepal at an agri-vet shop when we were visiting one of our fellows. And here we have bottles of chlorphenicol next to the bottles of ciprofloxacin and next to the bottles of enrofloxacin. And although they say do not use without prescription of a registered veterinarian and for vet use only, you can actually just go to the shop, grab a couple of bottles of this and add it to the water of your chickens that your chickens are drinking. And you can buy all of them or one of them or whatever combination you want to have. So this is very problematic. And as I was saying, some countries have really low use of antimicrobials like Bhutan, but that's because all of their antimicrobial provision systems in animal health and in human health, but in animal health specifically, are through the government. So and following strict guidelines in terms of treatment guidelines that they use. The other important thing here is data analysis. And this in the right is a photo of one of our team members, Professor Mark Stevenson, providing some training on epidemiology and surveillance to our fellows back at the vet school. But it's essentially we found limited skills for data analysis, and that means that capacity building is essential for this. And of course, that's also required for integrated analysis, where you can have analysis, combined analysis of AMU and AMR data, but also across the food chain. And that requires, again, collaboration between sectors, because depending on the country, sometimes data from primary production in animals is in the agricultural sector in the government, whereas data in food is coming from the health sector. And so combining them is really, really important. So one of the things that we did in AMROSI was a regional workshop on surveillance in Bali. This was in October 2024. And so here we have participants to that. We had a number of different activities there, and it was very, very, very good. Data reporting, again, important part of the process. And it's not useful, data is not useful until it's reported for decision-making, risk analysis, etc. So one of the things that we've been supporting is for countries to be able to report antimicrobial use data to the database in the World Organization of Animal Health, or reporting AMR data from animals to the FAO system, which was launched in 2024, and it's called INFARM. And I also work in South America as a consultant for FAO, so I was participating in that launch as well there. And so data use and decision making, very important for policy change and for appropriate antimicrobial use. And an important thing here is to get government buy-in. So build a case so that you have sustainability in these projects that will generate data over time, and then these data can be used for these purposes. Same with appropriate antimicrobial use. There's requirement for locally developed treatment guidelines, focus on paraprofessionals in many countries because they are the ones that are prescribing and using antimicrobials, and establishment and continuing treatment records where they don't exist or they do exist. So for this, we had another regional workshop in February last year, so a year ago, and we had a lot more participants from all the countries. And this was how do we use data for policy, and how do we use data to create treatment guidelines? So one of the outcomes of our work over the last 7 years has been to develop treatment guidelines. So we've done that for a number of animals. First as part of Combat AMR in Samoa and Fiji, but then over the last 2 years, we've been able to develop similar treatment guidelines for Timor-Leste, for Papua New Guinea, and that was launched a couple of weeks ago, and also for Indonesia in cattle. And this is a QR code in case you want to go and see these resources online at our website. So in summary, we need balanced One Health approach where we have equitable resources for the sectors participating in this. The One Health approach works when you have similar or equitable access to resources. And this is not just between different disciplines, thinking about human, environment, and animal, but also thinking about society as a whole, where rural and urban and mobile communities are all represented in this as well, with inclusivity, with equity and access. And I'm not making any of this up. This is all part of the One Health approach from the quadripartite. But in practice, it means that we need to think from the design, how we're going to support systems that are not in health, that are food, environment, animal health in these systems. So importantly, ownership and sustainability means that between the sectors participating, there's got to be cooperation and handshaking for enhanced lab capacity, enhanced surveillance capacity, and decision making. And with that, I want to finish saying that if we want to reach the Sustainable Development Goals that have been established and that are, 2026, so 4 years away, the only way to achieve this is with partnerships to this. And AMR has impact on poverty, on hunger, on health, on sustainable cities and communities, clean water and sanitation. All sorts of different parts of the Sustainable Development Goals are affected by AMR. And so partnerships are essential. And with that, I want to say thank you very much. Thank our funders, thank the countries that we've been working with, and again, the QR code for the treatment guidelines if someone wants to see them.
Thank you, Mauricio. I think I know that some people have to leave at 9:30, which has just gone past, so we're slightly over time. I'm happy to take any questions that people might have. I'm sure there's lots of questions that people have for both Denis and for Mauricio. If you want to pop them in the chat, that'd be great. Or if you want to, I'm not sure, Caroline, are people able to unmute themselves, or do we have to put their hand up and we can unmute them? We haven't had any questions come through just yet.
If somebody wants to ask a question in live, then let us know and I can unmute you.
I have a question for Jenny, actually. So thinking about the antimicrobial use data from the last period of time that you showed, and that significant reduction over time, how does that compare with what's known in other countries? And considering your European background, is this similar to what happens in Europe, or is it higher, or how does it compare? You're mute. You are mute, Denis.
Yeah.
Yes,
so It's a very good question, Maurizio, but I don't have the data to put side by side. Laura Hardefeld might have an idea because she has done those calculations, whether she is aware of other places and, whether it's within Australia or abroad. My general feeling, having been in others, is that particularly in the Scandinavian countries, it would be, we are far above and still above what is being used, for the simple reason penicillin gentamicin for colic surgeries is generally relatively standard use everywhere. But when we were in Copenhagen, if we wanted to use gentamicin, we had to call somebody from the veterinary office, the state veterinary office, to ask permission, right? So whereas this is liberally available here and in many other countries, right? So there are some legislative issues or legislative restraints in certain countries which will effectively make the use of certain antibiotics much less than you will have here. But it would be interesting to compare.
Danny, do you think that
Thank you.
actually in the Scandinavian countries or in Europe as in general, that some of the increased restrictions on what you can and can't use or the regulations around antimicrobial use are because horses are a food-producing animal in those countries, whereas in Australia, perhaps the US, they're not, and so there's less regulation around them?
Yeah, well, first thing is that every horse, or not every horse, every equid, so even if you have a donkey in your backyard, in Europe needs to have a passport, so they're all identified animals, and there needs to be that traceability. And so there are things you can and can't use from a legal perspective. Yes, that is a big driving force to that. It also has downsides, right? It also sometimes has a counterproductive effect. We have to be aware of that, is that certain higher class antibiotics may be used because the lower class doesn't have a labeled indication for the particular disease. So if you really want to follow the strict regulations, it actually pushes you to use something that is not indicated in that framework. So, and then there's a big issue with dosages and things like that, where the labeled dosages are not there. And so you're actually, if you want to provide what is evidence-based and so forth, you find yourself in illegality. So you might be using products at a homeopathic dose just to follow the law and not get in trouble. So don't think of that system as being the perfect Valhalla to go to, but it definitely has a massive impact. I think the other thing is that regulatory boards, like, you do get in trouble. You do really get in trouble with your vet boards if you don't do the right thing, which I don't think is something that happens here at present. And that culture shift about you will get in trouble with your vet board these days for giving antibiotics inappropriately, whereas I still think that in this country we are getting in trouble for not giving antibiotics.
Yeah.
So that's a culture shift.
And I guess given that, thanks, Denny, that's excellent. I do think that there's no perfect system that this is the perfect system. We should all move to that. I think there's bits of everybody's system that work well and then not so well. Maurizio, you made a few comments there around some of the One Health aspects and the equity. And I guess one of the things that I thought was interesting was that there's lots of opportunities for data sharing, but you need to have data to share. And you said that the publications from Nepal was around the ESBLs in animals, in people weren't coming from animals. Where were they coming from?
From themselves, I suppose.
ESBLs in people coming from people. How does that work, Maurizio?
Yeah, well, and that's the thing. So one of the
I've heard
issues
Peter
that we
Collignon talking. He says it's all from animals.
yeah,
What's going
because one
on?
one of the issues that we've been having to deal with, and these are reports from different countries, is the people who write them say, well, there's there's this sporadic situation happening, but that means that animals are transmitting ESBLs to people. When the bulk of the data says the opposite, that people are transmitting ESBLs between them and animals between them and maybe to the environment in each sector, but that's it. So we've had to go through reports multiple times to change them to actually reflect what the data says and not preconceptions. So that's been a significant issue. Yeah.
And I guess you've been to a few countries now, looked at a few different setups there. If you're able to make one change in lower middle income countries that would make a
Mm.
big impact on animals, I'll just put you on the spot, mate. What do you reckon would be the best bang for buck? Where's the biggest return on investment? From an animal health point of view, what would make the biggest difference from looking at AMR
Yeah.
and
Probably
animal?
vaccination, higher investment in vaccination for animals. We have very good vaccines for poultry. Poultry is the most consumed meat around the world. And a lot of the problems that people are trying to treat for are diseases that you can prevent through vaccination. So I think vaccination would be one, and then the next one would be animal health system strengthening through laboratories and access to diagnostics. Yeah.
Fantastic. I'm conscious that we've gone over time, and there are still 20 people who are valiantly holding on, probably hoping that I'll stop talking any second now. So I'll grant their wishes. Thank you both for some excellent and thought-provoking talks this morning. And I hope our participants enjoyed it. If they enjoyed it half as much as I did, they will have enjoyed it enormously. So thank you very much.
Thank you very
Caroline,
much.
do I need to do anything more?
No, that's all. Just to say, our next session is going to be on the 18th of March on I think the pediatrics. This whole session has been recorded, and we'll pop that up on the NCAS website later this afternoon. Thank you so
Fantastic.
much to everyone for
Thank you
attending.
very
Thank you to our
much.
Thank
presenters. Thank
you.
you to
Thank you
James for
very much. Have a
hosting.
great day, everyone.
Have a
Thank
great
you,
day.
everyone.
Bye.
Bye-bye.